and this is now WHO's roadmap, accepting the recommendations from SAGE as a result of the meeting on Wednesday, what you see in this roadmap is the inclusion of boosters as part of the schedule to achieve the best impact of vaccines. And what I want to emphasize again, that Dr. Cravioto mentioned and then I reinforced, and I'll do it just one more time, this does not mean giving boosters as a priority to everybody in all ages and all priority groups. We continue to have the highest focus on the full vaccination of the highest priority groups. And those priority groups are what are laid out in this roadmap. So boosters are part of the vaccination program, but it doesn't mean unfettered use to all ages. In fact, specifically, I'll just point out that in the 5 to 11-year-old age group, there is no evidence yet on the use of boosters in that age group. The update to the recommendation for the Pfizer product is only for the primary series. So we will continue to emphasize the principles that are laid out in the roadmap, and then it is the product recommendations about the doses that are used to achieve that best impact in the highest priority groups. Thank you.
Thank you very much. Next question goes to Donato Mancini from the FT. Donato, please unmute yourself.
Hey folks, good afternoon. So does the SAGE update mean that the WHO is now relatively upbeat about supply projections for 2022? I know the guidance does not include different types of vaccines, but if there is a switch to a different type of vaccine to contrast Omicron or other variants, how do you think things will change? And just to get this absolutely right, the WHO has adopted these recommendations. Is that correct? It now forms part of what it is saying we should do, correct? Thank you.
Thank you. I'll answer the last part of your question first because it's the most simple one to answer. Yes, these are WHO recommendations. They're up on the web. They are WHO's position. The second question, which is, are we upbeat about the supply situation? And I'd like to address this in a couple of ways. Again, we'll refer you to the, and we do provide all the materials that are reviewed at SAGE on the website. So you do have access to the materials that were presented on the supply side of the considerations at the December 7th meeting. Our analysis of the global supply situation for 2022 is a positive analysis. What the analysis shows for our projections on the total global availability of supply is that the number of doses that are being produced on a monthly basis and that accumulation does provide sufficient supply for most of the scenarios of how countries would choose to deploy vaccines. And that is inclusive of scenarios of very high use of vaccines if countries were to set as their objectives and achieve the objectives of high population coverage of 70% or more, and if countries chose, all countries chose, to be giving booster doses quite broadly. In that rather implausible scenario of achieving all of that by the second quarter across all countries by the second quarter of 2022, our projection is that there would nevertheless be sufficient global supply to meet that kind of scenario. Now, what that doesn't say is that will not be achievable if the distribution of those vaccines is highly inequitable. It simply means that there is likely to be sufficient supply should that supply be distributed in an equitable way. And that is the bigger task, is assuring that supply is getting to the places where it's needed. And I'll just remind you that we are still in a position where there are 34 countries that are below 10% coverage at this point. I'll just repeat that, below 10% coverage at this point. and a larger number of countries, approximately 86 countries that are below 40% coverage. Now that is as a result of the accumulation of the severe supply constraint in 2021 and the relief of that supply constraint really only in the past 2.5 months. And so we do see a very positive outlook for supply, but only if the continuation of sharing of doses continues, and if manufacturers continue to supply COVAX with the commitments that they have, and to AVAT with the commitments that they have.
Thank you so much both for the question and a very comprehensive answer. And let me just again flag, please raise your hands. We still have room for more here. Next question goes to Sarah Jerving from DivX. Sarah, please unmute yourself.
Thank you so much. Can you please clarify the percent figures around moderate to high primary series coverage? Is that above 50%? And what are the figures that are for the low rates of primary series coverage? Is that below 50%? And then what is the age threshold in the high risk in moderate or for high risk individuals in moderate to high countries? Thank you.
Do you want to start with Professor Cravioto?
I would defer the answer to Dr. Hombach, if you don't mind.
Dr. Hombach.
We have not specifically defined the coverage rates because they may differ from country to country in terms of what is achievable. But the figures you have given are absolutely reasonable figures. But we have refrained from specifying this because what we expect is every reasonable attempt to achieve high coverage or highest coverage. And what we don't want is a situation in which countries essentially do not progress and don't go to the next lower priority population because they cannot achieve a certain level of coverage. That is the reason why we have not specified this, but the figures that you have given are reasonable. In relation to the older age definition, again, we are not exactly specifying this because, again, this is somewhat dependent, but 60 years or 65 years are reasonable thresholds that countries should consider when they implement this roadmap.
Thank you very much, Dr. Hombach. Anybody wants to add? Dr. Wilder-Smith or Dr. O'Brien? Dr. Wilder-Smith, maybe, yeah.
Well, every country has a different population age structure. In some countries, the proportion of people above the age of 60 is only 5%. In others, it's far more than 20%. And that is one of the reasons why we left a decision for a threshold to the countries. But typically it's 60, but some countries may choose for 55 or 50 or others for 65.
Dr. O'Brien.
I really like this question because you're getting quite concrete about what the guidance is, and I think what's important is that we give countries the direction to head in based on the evidence. The question about what the age strata are, I think Dr. Wilder-Smith and Dr. Cravioto have answered that clearly. Each country has a slightly different age demographic. And is experiencing the pandemic. We don't want to create sort of hard and fast rules about what the specific age is, and I think they've answered that. On the issue of these 4 categories of vaccine coverage in a specific risk strata for which you then might move to the next risk strata, and as we've described, we have a sort of low, moderate, high, and very high. Again, we haven't provided a specific number there. But it's, I think we can give some general categories, some general directionality about what the committee has in mind, what what we would consider moderate coverage, what we would consider high coverage. And certainly that's based in part on the experience of countries. And what we've seen is that there are a limited number of countries that have been able to get above 70% coverage. And so we would consider something above 70% coverage as going into the very high category. We've also seen that for within any risk strata, that the first effort, the sort of first push on vaccinating people tends to get somewhere around 40% coverage. And so these are some benchmarks. They're not in the document, but I don't want to leave it completely ambiguous about what we mean by low, medium, high, and very high coverage. So I'm just giving you some kind of benchmarks around what those numbers look like. And obviously, when you think about the routine immunization program, again, of a different age group, but young children, we would consider very high coverage, upwards of 90% coverage.
Thank you very much. And Professor Cravioto wants to come in. Are you unmuted?
Hello.
Here you go.
One thing that has come up, which is clear, and also an answer to the question, is how do we approach groups that we have not really vaccinated in many low and middle income countries as part of our vaccination programs. And that includes, for example, older people who are now a high priority group. And this is why we go back to what Dr. Hombach said, that we cannot put constraints in percentages to something that is really an evolving process. To convince older people to come out and get vaccinated against something that they have never been really accustomed to do is something that takes some time. And therefore, as the process continues, we don't want to wait until we get a certain percentage of that population group vaccinated before we start thinking about the others. Therefore, putting this type of tight constraints and percentages is not something that we're looking forward to, because that is also not in help of the implementation of these vaccination programs, which in many countries are a new process that has to be developed, tested, and especially constructed as it moves on. Thank you.
And indeed, if I may add, many countries are struggling to reach the older age groups, especially low to middle income countries that do not have a programmatic approach on how best to reach older age groups. And this roadmap also provides links to training resources, tools, and guidance to help those countries really reach the older age groups. And the older age groups remain the highest priority group.
Thank you very much all for these clarifications. Sarah, Geraldine, you had a follow-up. I assume this has been covered now in the discussion. Otherwise,
yes.
Please raise your yes. Thank you.
Thank you so much. When Dr. O'Brien spoke, gave the 40% to 70%, I just want to clarify that that would be within the strata of a high group. It's not like overall population, it's within that strata, correct?
That's exactly correct. And it does, for those of you who've been covering this for a long time, we want to be clear. It is very clear in the document, but you have to read it carefully, that it is vaccine coverage rates. It's the coverage rate within the strata. And that's how you read across the columns. It's not the total population coverage that we're referring to, which was referred to in the previous roadmap. And that's why we are calling this a major revision to the roadmap. They're different concepts.
Do you maybe want to elaborate that a little bit?
Yes, in the previous roadmap, the previous roadmap was the roadmap for prioritization in the context of constrained supply. And it specified which groups were the highest priority groups when you had only enough supply for 10% coverage of your total population, 20% coverage of your total population, and down to 50% coverage of your total population for that supply. We have sunsetted that roadmap. This revised roadmap is specifying the optimization of use of vaccines across risk strata. And what it explains is who are the groups that you start with in terms of vaccination. And all countries have now started vaccination, so they're using the highest priority risk group as the primary target to whom vaccine would be offered. And as both supply increases and the program achieves coverage within that strata, how far do you go with your effort in that strata before you start to deploy vaccine to the next risk group? And that's what these low, medium, high, and very high coverage levels refer to. In other words, if you only have 10% coverage of your highest priority group, a country should continue to focus on getting coverage in that priority group rather than distracting supply and the program effort into lower priority groups. The most important thing is to get everybody in that highest priority group, to the best of the ability of the program, covered with primary doses and then booster doses. And of course, any program is going to start to work in multiple risk strata, but only doing that once achievement of relatively good coverage has been achieved in the highest risk strata.
Thank you very much. A very important clarification. And I see Corinne Gretler has a follow-up as well.
Oh, thanks
Corinne,
so much
please
for
go ahead.
taking. Thank you so much for taking my question again. I was just wondering, did SAGE discuss the roadmap on how to develop vaccines as new strains emerge? And if so, what were some of the conclusions reached so far?
So the emergence of Omicron has really highlighted the need to even emphasize much more than before that we have to prioritize the older age group. So really provide direct protection to the vulnerable age groups. Now knowing that Omicron, that the vaccine impact for Omicron is reduced for milder disease and for transmission. And it's because of this. So although we really have a big emphasis on protecting the schools and children, it is less urgent to vaccinate children. We still have to prioritize those who are at highest risk of severe disease.
Thank you very much, Dr. Wilder-Smith, for that clarification. That brings me to a question we have online here, which may be a good follow-up again. Does this booster, or will this booster be the last one, or will there be new ones for new variants of concern? The question which has been debated publicly a lot. Dr. O'Brien, maybe.
We certainly are focusing the attention in this roadmap and in the product-specific recommendations on the updates that are inclusive of giving a booster dose. We will continue to be evidence-driven. We're fully aware that there are some countries that are making decisions to deploy let me call it additional boosters. I think we're not even quite clear how to use the terminology here. But there are some exceptions that I would like to point out. We've already provided a recommendation for individuals who are moderately or severely immunocompromised, that the usual recommendation for a primary series, a 2-dose recommendation, does not provide the same kind of immune response as in people who are not significantly immunocompromised. And as a result, our recommendation for immunocompromised persons is that they receive 3 doses of vaccine as part of their equivalent of primary series. And we reference that 3rd dose as an additional dose. It's not being used as boosting, which is the returning of your primary series response after waning over time. So for those individuals, they also require a booster dose, just as in for people who are not immunocompromised. And so for those individuals, it would be a 4th dose. But generally speaking, we have no evidence that is of sort of settled science about giving a subsequent booster dose to a broader group of people. We're fully aware of the data that is emerging from a limited number of countries, Israel in particular, around a decision to give a fourth dose, and that evidence that is starting to emerge from Israel that we're following very carefully. But at this time, SAGE is clear, and WHO has adopted the recommendation that we are referencing a single booster dose, and we will continue to follow the evidence. What Dr. Wilder-Smith was also referring to in the previous question is that SAGE did discuss and did review the situation with Omicron, the situation of the emerging evidence on the performance of the vaccines against Omicron, the performance of both primary series over time, and the performance of booster doses specifically for Omicron in relation to their performance with Delta. And it's a timely update to this roadmap to provide the provision for the use of booster doses, again, specifically highlighting that it is the highest priority group that must remain the focus, and getting coverage in all countries for that group so that we can really address the severe end of the disease spectrum.
Very good. Thank you very much. That leads to another question, which also came in online. Are the general, we discussed it in the beginning, I think, but it seems to be worth mentioning again. Are the general recommendations on boosters for every EUL vaccine or just Pfizer? Maybe you want to go back to Professor Gravioto, because he mentioned it in the beginning.
Yeah. The one we have now reviewed and updated is the Pfizer-BioNTech vaccine, because that is the evidence that we had so far. And we are in the process of reviewing the other vaccines that have been approved for the same purpose as the evidence becomes available. I don't know, Dr. Wilder-Smith would like to expand in that.
No, indeed, we are in the process of updating all the EUL vaccines with regards to boosters. When also data become available for an age indication or extension to younger age groups, we will also update accordingly.
Thank you very much. And I see Donato Mancini has his hand up still, or again, Donato, a follow-up?
Sorry. Yes, I do have a follow-up. So my apologies if you answered this. This change to the guidelines does not take into account the potential need to switch to targeted vaccines. Is that right? This is just an ancestral wild type vaccines. This is the first question. The second question that I have for you is on heterologous boosting. You're basically saying the heterologous boosting can be done, mix and match can be done for every type of vaccine that you have under EUL. Is that correct or not? Thank you.
All right. Yeah, exactly. Let's do that. Thank you very much. We'll start with Kate O'Brien for part one, and then Professor Gravioto will come to you for part two.
I'd like to just perhaps correct a little bit about the question that you asked on the first one. You know, are these recommendations specific to the ancestral strain? The answer is no, it's not specific to the ancestral strain of the virus. These are contemporary recommendations in the context of Omicron and Delta, which is in some places still circulating. So this is not about looking back at ancestral strain evidence. We're looking at evidence across all of the evidence that has come through across time, which considers all of the variants, but specific reference to the Omicron variant as well, which, as I mentioned, SAGE has looked at. But I think perhaps this ties into a little bit of a previous question, which is about variant adapted vaccines. And of course, we don't have variant adapted vaccines at this point. We are following that very carefully with in WHO through a number of committees, specifically the Technical Advisory Group on the Composition of Vaccines, which is very tightly linked committee to the SAGE committee. And the TAG COVAC, along with SAGE, will be reviewing whatever the earliest evidence is from the manufacturers about variant adapted vaccines. And it will be the SAGE remit to provide policies on how those vaccines should be used, should they become authorized for use. It's the remit of the TAG COVAC to provide recommendations on the need for and the composition of those vaccines. So this roadmap update, with the inclusion of booster doses and the inclusion of adolescent vaccination and childhood vaccination, and about where do those kinds of vaccine doses, where do they fit in the priority scheme? This is in the context of the current epidemiology of what's going on around the world. So maybe just turning over to Dr. Cravioto and then Dr. Wilder-Smith about the heterologous mix and match on both primary and on boosting.
I think Dr. Hombach wanted to come in for the heterologous question.
Yeah, let me start, and then I'm sure my colleagues can add. So the topic is indeed very important, and we know it's programmatically extremely important for countries to have flexibility in terms of providing vaccines in a certain combination, in particularly if there is interruptions in supply. We have actually very systematically reviewed the data that are available, both in relation to primary immunization and combining different vaccine or different platforms here, as well as then in relation to booster. And we have released a policy statement end of last year, just prior to the holidays, that summarizes the information and provides guidance in relation to this. I think what is important to say that we do not have data in relation to all possible combinations, because obviously this is an, these are really many permutations, but there's clearly there's a couple of clear principles that emerge, and they are summarized in this statement on heterologous schedules. So for instance, for the Pfizer vaccine, for the, say, mRNA vaccines, as we are discussing here, there is relatively little benefit in coming up with heterologous or coming up with a second dose of a vaccine of a different platform, even though for vectored, for instance, it is pretty neutral. For inactivated, it is not neutral. It would be a slight decrease. If you start with an inactivated and come with an mRNA vaccine, then you have a significant advantage. And we have done the same analysis in relation to starting, so to say, as a reference vectored vaccines, and then looking at the trade-off in relation to inactivated vaccines or in relation to mRNA vaccines, and the same also in relation to inactivated vaccines. So we clearly make statements in terms of preferential considerations that countries should look into if they want to provide heterologous carriers for whatever reasons. So it's not necessarily an anything goes, but there is a significant flexibility. The other thing which we have pointed out is that for some of the combinations, we don't have many data, so it's very often relatively small scale immunogenicity studies. There may also be a modest increase in reactogenicity with some heterologous combinations. So I think, and we actually refer in the roadmap, we refer to this document. So we have integrated it into the roadmap. There is much more detail in this document I referred to that was published, I think, on December 22nd. But the essence is in the roadmap as well.
Thank you very much, Dr. Hombach. Looking around the room, so to say, anybody wants to add on this one? If not, we have time for one last question, and this one goes to Rhoda Odiambo from the BBC. Rhoda, please unmute yourself. Rhoda, can you unmute yourself? We seem to not have sound from your end. Now we're good. Please go ahead.
Hello, can you hear me?
Please go ahead, yes.
Hello, can you hear me?
We do, but it seems like you cannot hear us.
I can hear you now. If you can hear me, I can ask my question.
Yes, please.
Okay, thank you so much. My question can be answered by either Dr. O'Brien or Alejandro. in terms of children, your recommendation that children between the ages of 5 and 11 ought to get the Pfizer vaccine, would you also be recommending that they get a booster shot, especially those who are living with underlying conditions? Thank you.
Dr. O'Brien, please.
Yeah, so let me be really clear on this. The roadmap specifies where children 5 to 11 come in the prioritization scheme. We're not making a specific recommendation that children should get the Pfizer vaccine. There are additional vaccines that have stringent regulatory authority authorization for younger age strata. We will be updating our recommendations according to the evidence on the subsequent products, and we will be coming forward with those recommendations and updating product by product the recommendations. So there's no product specific recommendation for 5 to 11-year-olds at this point. We've simply, it's just a timing issue of which ones we're able to do in which order, and we want them to come out as quickly as possible so that we don't hold them back as we get them done. But I do want to also be specific that with respect to children 5 to 11 years of age, there is no product for which there is evidence on booster doses for those children. So we, although, and you will see in the roadmap that we're specific in the table of the groupings of priority, that for those who are under 12 years of age, we simply don't have evidence yet on the need for or the evidence on the performance of boosters. So let's just be clear that we're talking in that age group at this point only about the primary series. And I'll just reinforce again that we will be updating recommendations on other products where there is evidence for younger age groups below 12 years of age. We will be incorporating that evidence in our review, and we will be aligning with the regulatory process as well. I don't know if others would like to add anything to that.
A quick look into the room. I don't think so. Then I thank you all very much, the panel, of course, as well as the many journalists online. With this, we conclude the virtual press conference on the outcomes of the SAGE extraordinary meeting. The meeting was held on 19 January. And we thank Professor Alejandro Cravioto, Chair of the SAGE, Dr. Kate O'Brien, Director, the Department of Immunization, Vaccines and Biological, Dr. Annelies Wilder-Smith, Technical Advisor to the SAGE COVID-19 Working Group, and Dr. Joachim Hombach, the Executive Secretary for SAGE. Thank you all very much and have a good day.